Good
Good evening to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Bharat J. Parmar. Sir is MBBS, MD, DHA, FAIMS, Professor and Head of Pediatric Department at Zydus Medical College and Hospital, Gujarat. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is management of hypothermia in newborn. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, sir.
evening. I'm very thankful to IGCP Group for giving opportunity to me for highlights my views about hypothermia in newborn. So for the intake survival of the newborn, it required antenatal care, safe delivery, neonatal resuscitation, prevention of neonatal hypothermia, prevention of neonatal hypoglycemia, promotion of breastfeeding, prevention of infection, and the recognition of high-risk baby referral and the management. So temperature regulation is one of the most important aspect of the neonatal care, even in a normal newborn. Fetus who enjoy isothermic environment 37 degrees centigrade in utero and is suddenly exposed to low environmental temperature at birth, leading to rapid drop in his or her temperature zero point 0.3 degrees centigrade per minute by all mode of heat loss, that is evaporation of amniotic fluid, convection due to wind movement, radiation due to temperature gradient, and conduction to substance in a contact with skin, there is linen. Mechanism of heat loss in heat regulation, evaporation due to evaporation of amniotic fluid from the skin surface of newborn, conduction by coming in contact with a cold object such as cloth and weighing tray, and convection by air current where the cold air replaces warm air around baby due to open window and fan, and the radiation to the colder solid object in vicinity like wall. So these are the mechanism of heat loss in newborn. The normal thermoregulation, the sudden cooling of neonatal skin stimulate cutaneous thermoreceptor which convey the information to the heat regulating center in the preoptic anterior hypothalamus, and efferent from this center are mainly sympathetic, adrenergic in nature, and stimulate various mechanisms for heat conservation and heat production as follows. A heat conservation by the peripheral vasoconstriction, heat production by increased muscular activity, there is crying, limb movement, and shivering mechanism are not mature in newborn, and heat production by metabolic thermogenesis. So these are normal mechanism in thermoregulation. Metabolic thermogenesis. The metabolic thermogenesis is the predominant mode of heat production in newborn, which involve oxidation of metabolic fuel, brown fat, in the presence of glucose and oxygen. And the brown fat is highly active metabolic substrate due to large number of the mitochondria predominantly present at the nape of the neck, intercapsular region, axilla growing, and around the kidney and adrenal. And in full term, appropriate gestational age baby the brown fat accumulate for 4% of the body weight. Since most of it accumulate in the last trimester, in the preterm have much less brown fat and hence they are more susceptible to hypothermia. So in preterm baby, there is a lack of this brown fat and prone to develop hypothermia. Thermoneutral environment. Human body can maintain its temperature only within a limited range beyond which hypothermia or pyrexia results. However, the maintenance of the temperature even within this range require constant metabolic activity either to generate heat or to increase evaporate heat loss. There is a sweating. Thermoneutral environment is a narrow range of temperature at which baby can maintain its temperature with a minimum metabolic activity and oxygen requirement. And it varies according to the gestation, the birth weight, and the postnatal age. Range from 33 to 31 degrees centigrade in full term, 35 to 33 degrees centigrade in very low birth weight baby, higher value of the range for first day of the life, and the lower value for the fourth day onwards. Neonatal temperature should always be recorded by low reading rectal thermometer to detect early hypothermia. Rectal temperature represents body core temperature 0.5 to 1 centigrade higher than the surface temperature. The spectrum of temperature in newborn spans from severe hypothermia when the temperature is less than 32 degrees centigrade, moderate hypothermia, the temperature is 32 to 35.9 degrees centigrade, and cold stress, the temperature is 36 to 36.4 degrees centigrade. Normal temperature is 36.4 to 37.4 degrees centigrade. In the fever, there is a hyperthermia. The temperature is 37.5 to 38.5 degrees centigrade. And hyperpyrexia, the temperature is more than 38.5 degrees centigrade. Hypothermia. Hypothermia is more common and a serious problem in newborn than fever or hyperthermia defined as skin temperature is less than 35.5 degrees centigrade or core temperature less than 36 degrees centigrade. The severity of hypothermia can be classified. Mild hypothermia, there's a cold stress, temperature 36 to 36.4. Moderate hypothermia 32 to 35.9. And severe hypothermia, the temperature is less than 32 degrees centigrade. Risk of hypothermia. All the newborn within first 12 hours of the life during neonatal transport, preterm baby, IUGR, neurological impairment, damage to the hypothalamus, birth asphyxia, anesthetic medication, hypoglycemia, irregularity in their skin integrity, neural tube defect, omphalocele, gastroparesis, and ichthyosis, and the lack of awareness regarding thermal protection of newborn among the caregivers. So these are the risk factor for hypothermia in newborn. Etiology of hypothermia. The newborn are more susceptible to hypothermia than adult due to disproportionately higher heat loss from a larger surface area and the lesser fat insulation and inadequate shivering thermogenesis, as metabolic thermogenesis is the only effective thermal defense in them, and hypothermia is commonly seen in newborn with lack of brown fat in preterm baby and small for dead baby. Substrate deficiency, there is a birth hypoxia or birth asphyxia or hypoglycemia, they prone to develop hypothermia. Circulatory insufficiency, infection, and the shock, they prone to develop hypothermia. And impaired central control, there is disorders affecting hypothalamus and neurological pathway, it prone to develop hypothermia. In addition, cold exposure during procedure and during transport prone to develop hypothermia and further contribute to hypothermia in the sick baby. The pathogenesis of hypothermia. The prolonged hypothermia affect various metabolic activity leading to complication. There is hypoglycemia, cellular hypoxia, metabolic acidosis, septicemia due to impaired immune function, and the poor weight gain due to diversion of metabolic substrate for heat production. In addition, impaired blood flow, blood-brain barrier due to acidosis and other factors in hypothermia, and increased risk of kernicterus at a relatively lower bilirubin level. Pathogenesis of hypothermia. First, there is a cold stress, non-adrenaline secretion, brown fat oxidation lead to peripheral vasoconstriction, consuming glucose and oxygen, and there is a cellular hypoxia, acidosis, and pulmonary vasoconstriction and hypothermia, and hypoglycemia, hypoxia, and acidosis, they prone to develop hypothermia. Clinical expression of hypothermia. Clinical expression of hypothermia depend on its severity, including changes in the activity. There is a restlessness with excessive crying or body movement to generate heat in early cold stress and following by sluggishness and inactivity. The skin changes, the cold clammy skin, especially over the limb, followed by generalized mottling and the pallor due to vasoconstriction, and finally develop scleroderma. The scleroderma is an important sign of hypothermia in newborn, characterized by hardening of the skin and best appreciable over the cheek and the shin of the tibia, and pathologically it signifies solidification of saturated fatty acids in the subcutaneous tissue. Depressed autonomic function, there is a bradycardia, slow breathing, and hypotension. The diagnosis of hypothermia. The diagnosis of hypothermia rests on a rectal temperature recorded by low reading thermometer and simultaneous recording of the surface temperature. Auxiliary temperature with the surface, the core temperature difference more 2 degrees centigrade indicates shock. Clinical features of neonatal hypothermia. The peripheral vasoconstriction, it lead to acrocyanosis, cold and pale extremities, and the decreased peripheral perfusion, and central nervous system depression. There is a lethargy, hypotonia, bradycardia, apnea, and poor feeding, and increased metabolism. It lead to hypoglycemia, hypoxia, metabolic acidosis, and increased pulmonary artery pressure. There is a respiratory distress and the tachypnea, and the chronic sign DIC, there's a disseminated intravascular coagulation and the poor weight gain. So there are the clinical features of clinical hypothermia in newborn. Preventions of hypothermia. Preventions of hypothermia is perhaps the most important step in the neonatal care, include at birth by conducting delivery in a warm labor room at 28 to 30 degrees centigrade, and pre-warming of resuscitation area and receiving the baby on a pre-warm towel, wiping the baby well, and wrapping in a dry warm linen, and early breastfeeding to prevent hypothermia. In perinatal ward, by rooming in mother, keeping the room warm and baby covered, and delayed bath till 24 hours and minimum handling. Preventions of hypothermia. The strategy to prevent hypothermia are listed below. High-risk mothers should be identified during antenatal period and referred to the center equipped to provide good quality of obstetrical and neonatal care service. In labor room, warm microenvironment should be created to provide warm welcome to the baby at birth, and the baby should be dried promptly and covered effectively at birth. And do not give birth to the baby at birth, and baby admitted in NICU should not be bathed. Instead, they should be sponged. The nursery and the room temperature should be maintained around 28 degrees centigrade plus minus 2 degrees centigrade. Standby incubator should be kept warm and ready all the time to receive small, sick, and the cold baby for a incubator care. The baby should be effectively covered and clothed with cap, socks, and the mittens. And the fomites, there's the inanimate objects that come in direct contact with the baby should be pre-warmed, namely cord, linen, cloth, infused, X-ray film, and so on to prevent hypothermia. They take special care to prevent hypothermia during procedures and during transport. Application of oil or liquid paraffin to the skin reduce the risk of evaporation and heat loss and prevent hypothermia in newborn. Skin to skin contact provide excellent source of biologically controlled heat source. Apart from providing warmth, it promote bonding and the breastfeeding. There is a kangaroo mother care. The mother healthcare worker and nurse and pediatrician should be provided with the knowledge and skill to assess the baby temperature by touch and to prevent hypothermia. When the trunk is warm to touch and extremities are reasonably warm and pink, indicate that baby is well and at satisfactory body temperature. However, when the trunk feels warm to touch and extremities are cold and pale, it suggests the baby there's a ash cold stress. But when both the trunk and extremities are cold and touch, the baby has hypothermia. Kangaroo mother care. Kangaroo care, keeping the baby nestled inside the mother cloth with the close skin to skin contact is the best method to provide warmth and to prevent hypothermia in newborn, which help in promotion of breastfeeding and emotional bonding. In sick baby NICU, by the warm room, individual heat source, incubator and radiant heat warmer, and the minimal exposure during diagnostic and therapeutic procedures. During transport, with the use of transport incubators and thermocol box to prevent hypothermia in the newborn baby. WHO in 1997 recommended a set of interlinked measures. There is a warm chain during and soon after the delivery to minimize the heat loss in the newborn. The failure to implement any one of them will break the chain to put the baby at risk for hypothermia. So WHO recommended in 1997 there is a warm chain. So 10 step of one warm chain recommended by WHO in 1997 There is warm delivery room, immediate drying, skin to skin contact, breastfeeding, bathing and weighing postponed, appropriate clothing and bedding, mother and baby together, warm transportation, warm resuscitation, training, and awareness raising. The management of hypothermia. The management of hypothermia in newborn include a gradual warming of the baby in an incubator or warmer, and the sudden warming may precipitate apneic spell, and the temperature gradient between baby skin temperature and environmental temperature should be never exceed 1.5 degrees centigrade. However, this severely hypothermic newborn may be warm rapidly till skin temperature reaches 34 degrees centigrade, followed by slow warming. Continuous temperature monitoring by skin probe and servo control incubator and warmer are preferable as they automatically adjust heater output according to the baby skin temperature. Substrate supplementation, there is a intravenous glucose 10%, there is a 2 ml per kg bolus and oxygen to fulfill increased demand of metabolic thermogenesis, and intravenous hydrocortisone 5 milligram per kg 8 hourly for 3 to 5 days may be used in case of severe scleroderma. And treatment of complication, the treatment of infection, hypoglycemia, acidosis, hypoxia, and the bleeding manifestation. Strategy to keep the baby warm. There's a labor room, lying in the ward, NICU, operation theater, and during transport. In the labor room, the baby should be received in a pre-warm bassinet having gradient heat source, and the infant should be immediately dry and effectively covered with a pre-warm sheet or a blanket. And the head constitute large surface area of the baby. It must be dried effectively, and the bath should be delayed to the next day, and the no baby should be bathed in the labor room, and the low birth weight baby must be immediately transferred by the nurse to the warm environment of the nursery and housed in an incubator and open care system when indicated. Lying in the ward during the winter month, the baby should be next to the mother rather than separate cot, and the warm body of the mother serve as a biologically controlled source of heat. In the extreme winter, the room can be kept warm with a heater and hot air blower, and the bowl of water should be placed in the front of hot air blower to increase the humidity. Oil-filled radiant warmer is preferred as it gives controlled heat and does not reduce humidity. And the baby should be adequately clothed with the woolens, and head, feet, and hand should be covered with the cap, socks, and the mittens. There is no need to bath baby in winter. Instead, sponging can be done on alternate day. In NICU, the high risk and the low birth weight baby must be transferred from labor room to the NICU by the nurse and kept in the incubator or open care system if the birth weight is less than 1800 gram or the gestational age below 35 weeks. The baby is hooked to servo control temperature system to maintain his or her mid epigastric scene temperature around 36.5 degrees centigrade. This system is so geared that it would be automatically maintain the temperature of the baby by increasing or decreasing the heat output depending upon the needs of the baby. When the temperature and clinical condition of the baby have stabilized, the baby should be enclosed in a Perpex heat shield or the cloth and provide with cap and reduce radiant heat loss. The application of oil or liquid paraffin to the skin, it reduces both the heat loss and evaporation loss. The temperature of NICU should be maintained around 28 plus minus 2 degrees centigrade, and the nursery baby should not given a bath and they can be spawned, and during the various diagnostic, therapeutic and surgical procedure, the radiant heat source should be used to keep the baby warm. When the NICU facility are not available, the preterm baby can kept in the warm with a hot water bottle or electric blanket, but this heat source should never come in direct contact with the skin of the baby. Operation theater. Infants are at a grave risk to develop severe hypothermia during surgery because of low temperature of operation theater, prolonged exposure, and evaporation loss following skin preparation and administration of the cold anesthetic gas. The infant should be placed on a circulating water mattress. An infrared overhead warmer should be affixed at a height of 45 centimeter above the infant. Fiber optic hot pipe system can be used effectively provide baby with a warm microenvironment from all sides. The rectal temperature of infants should be continuously monitored with the help of telethermometer. The transport. The availability of the transport incubator is ideal, but it is available only in selected hospital and the nursing home because of high cost. The baby should be effectively covered with the woolen, there is a cap, socks and mitten, and wrapped with cotton and tin foil. Skin to skin contact during transport is useful to keep the baby warm, and the padded can basket with a handle and hot water bottle inside the hampers can be improvised. The hot water bottle should never be come in direct contact with the baby because of risk of burns. In developing countries, the thermocol box with the transparent plastic lid can be used as a cheap, safe, and effective transport incubator. The thermocol box can be warmed with a hot water bottle before to start the journey. The prognosis in case of hypothermia. The prolonged and severe hypothermia is associated with high mortality and 25 to 50%, and the scleroderma and the bleeding manifestation, there is poor prognosis. Kangaroo mother care. Kangaroo mother care refer to the novel low-cost intervention in a care of preterm and the low birth weight infant by nursing them in a close skin-to-skin contact with the mother and other caregiver to promote temperature control, breastfeeding and emotional bonding, as well as to prevent hypothermia and infection in newborn. The first described by Edgar Ray of Colombia in 1978, the term derived its name from the similarities of marsupial baby care in kangaroo species. So, kangaroo mother care can be started at hospital, continued at home after discharge. The benefits of kangaroo mother care, the important benefits are to reduce risk of hypothermia in newborn, high rate of excessive breastfeeding, better weight gain with the early hospital discharge, the lesser morbidity in hospital and post-discharge, the better emotional bonding between the mother and baby, and involvement of the mother and the family in neonatal care, reducing stress associated with facility care. So these are the benefits of kangaroo mother care. Prerequisite of kangaroo mother care. Prerequisite for successful kangaroo mother care, it include baby should be hemodynamically stable, mothers should be willing with a good health and hygiene, support at hospital as well as home, and regular monitoring as well as post-discharge follow. So these are the prerequisite for kangaroo mother care. The procedure for kangaroo mother care involved following steps. Step 1, the pre-kangaroo mother care preparation include counseling the mother, spouse or other caregiver, demonstration of actual procedure and answering their queries and apprehension, provision of appropriate warm front open clothes for mother and baby, and provision for a suitable sitting arrangement. There is a reclining chair, kangaroo mother chair, and adequate privacy. Step 2, positioning of mother and baby pair involved, and the mother should be sitting or lying comfortably or preferably in a semi-reclined posture in the kangaroo mother care chair, and the baby head should be placed between mother breast in an upright position. The baby head should be turned to one side in slightly extended position to ensure open airway and adequate eye to eye contact with the mother. And the baby hip should be flexed and abducted in a frog position, and the arm should also be flexed. The baby abdomen should be at a level of mother epigastrium as the maternal breathing. It stimulates the baby and reduces the risk of apnea in the preterm baby. And the baby's bottom should be supported with a sling and binder, and both the mother and baby should be properly covered as one unit. Each skin to skin contact session should not last less than 1 hour to avoid frequent handling. Duration may be gradually increased up to 24 hours a day, interrupted only for changing diaper. Mother can eat or sleep in a kangaroo mother position with a proper support, preferably in semi-reclining position. The monitoring during kangaroo mother care. The baby during kangaroo mother care should be closely monitored, especially in initial setting, to ensure that neck is not too flexed or extended, breathing is normal, feet and hands warm. Mothers should also be educated to watch for this parameter at home. Feeding. Kangaroo mother care stimulate lactation and mother must train to feed the baby in kangaroo mother position, and she must also be trained to express her milk and feed the baby by spoon if required. And gavach feeding may be continued during kangaroo mother care depending on the condition of the baby. When to stop kangaroo mother care? The mother and the baby may be discharged depending on their clinical status with the adequate training and motivation to continue kangaroo mother care at home till it is comfortable and the baby is not wriggling out to show he or she is uncomfortable. Post discharge, baby on a kangaroo mother care should be followed up till 37 weeks or weight is 2,500 grams when the kangaroo mother care usually become unnecessary. Thank you.
Thank you so much, sir, for this wonderful presentation. We do have some question if you like to take that up.
Yes.
So, sir, the first question from our audience is uh, what are the clinical signs and symptoms of mild, moderate, and severe hypothermia in newborns?
So in mild, there is a that when you touch the baby skin, there is a cold. Also activity, there is a the inactive or sluggish and the restlessness. But when there is a severe hypothermia, the child having scleroderma and the bleeding tendency is there.
So, the next question is What diagnostic tools and protocols are most effective for early detection of neonatal hypothermia?
So early detection of hypothermia, see these extremities and see the trunk. If there is a trunk is a normal temperature is there, and there is a extremities also pink and not that cold, then there's a only the cold stress is there. But if the trunk as well as the extremities they are cold and pale, there's a definite hypothermia. So during the delivery, the preventions of hypothermia, it is one, there's a drying, and second, cover the baby. So early preventions and for hypothermia newborn during delivery, there's a drying and covering of the baby.
So, there is one last question. What are the immediate steps to take when a newborn present with hypothermia?
So I told in during the delivery, there is a drying and covering. And second important, there is a kangaroo mother care. There is a skin to skin contact. So keep the baby on the mother's abdomen and prevent benefits of this kangaroo mother care. One is temperature. It prevents the hypothermia burn. Second, there is a bonding. And third, it promotes the breastfeeding. So these are the advantages of kangaroo mother care.
Thank you so much, sir, for answering all our questions. That's all from our audience, sir. So, sir, before concluding, any take home message from your end?
So in newborn or in the preterm baby or the low birth baby, they prone to develop hypothermia basically due to the lack of brown fat. And also there's a large surface area of the head. So more heat loss is there. So for the preventions of hypothermia during delivery or during transport or during any procedure, so during delivery, there's a drying and covering. And during transport, uh, keep the baby covered. During procedure, uh, also cover the baby. So it prevents the hypothermia in the newborn, preterm, and the low birth weight baby.
Thank you so much, sir, for joining us today. With your permission, sir, I would like to conclude today's session. Thank you.
Okay, thank you. Good day.